Well, good morning, everyone, and welcome to the 16th Sven Paulin Lectureship in Cardiovascular Imaging. We have a real treat for us today with Dr. Matthias Friedrich, who will be educating us in the world of cardiac MR. But first, a few moments just to speak about Sven. As many of you know, Sven was born in Germany and received his MD at the University of Mainz. He then went to Cleveland Clinic, where he worked with Mason Sones, and went to Sweden, where he got his PhD in the nascent field of invasive coronary angiography, and that's his thesis on the right. He then came back to the United States and was at the Stanford, followed by the Peter Brent Brigham Hospital just across the street, and came here in 1970 as the radiologist in chief at the Beth Israel Hospital, a former Beth Israel Hospital. And during Sven's 25-year tenure as the chief of radiology, he really grew that institution from a very small, almost community hospital to a very internationally recognized group of academic radiologists. And as is typical at Harvard, when you reach 70, you must turn over your department chair. And so Sven retired in 1995, but he didn't leave us. In fact, first of all, during his 25-year tenure at the former Beth Israel Hospital as the chief, he had over 150 original reports, 18 book chapters. He brought X-ray angiography to the BI, and actually, when I was a fellow, I was looking through an old report, paper charts, and I found a cardiac ultrasound that was read by Sven, because he actually brought cardiac ultrasound here as well. And in the early 1980s, he was among the first to explore coronary MRI using a black blood technique. He went to Switzerland on a sabbatical and started doing coronary MRI at that time. And he was a very active participant in many of our cardiology conferences. I'm sure I saw Stafford on the list of being here. Stafford remembers, as does Julie and others. And he was always very supportive of cardiology, radiology, interaction, and collaboration. And that really is something that allowed me to foster my career and for which I will forever be grateful. But as I mentioned, he slowed down when he turned 70, but didn't leave us. He actually continued full-time in the Department of Radiology, continued to be an active participant in radiology and our Tuesday morning clinical conference. But he did transition to part-time when he turned 80. And in fact, when Sven turned 80, we had a big party. And that's when we established the Sven Paulin Lectureship. His whole family came and celebrated with us, with his grandkids. And it really was in recognition of his mentorship of cardiology and radiology trainees, junior attendings, and his participation in a lot of the conferences, where in fact he would often tell a lot of jokes and actually make some relatively outlandish claims or questions. And that always actually made the conference a lot of fun. Over the last 15, 16 years, we've had numerous luminaries in the field of non-invasive cardiac imaging come to speak to us. And Karen Ordovas spoke to us last year about CMR flow. Sven always loved life. He loved to joke, loved to tell jokes, loved to laugh, and he was relatively well. In fact, this was the last time that we were blessed to have him with us for the Sven Paulin Lectureship. David Oblumke gave the talk in September of 2013. We actually didn't know that Sven would pass away suddenly just a few months later. For many years after that, we actually celebrated together with Sven's family, often his son Magnus, who's a premier MR technologist over at Tufts. And sometimes we'd actually go to the Paulin home and have dinner with his wife, Birgit, and often his daughter, Suzanne, would join us as well. They're just very unfortunate. Just a few years ago, his wife, Birgit, passed away almost exactly 7 years after Sven. And this year, we're very fortunate to have Matthias Friedrich with us. Matthias received his MD from the Friedrich Alexander University in Erlangen, was an intern in medicine and cardiology at Charité University Medical Center, then went to Calgary, then went to Montreal Heart, where he is now the professor and chief of cardiovascular imaging at McGill University Health Center. He also holds a simultaneous appointment at Heidelberg University in Germany. He's often going back and forth between Canada and Germany. He really is a pioneer and a thought leader in CMR for many, many decades. When people hear about the Lake Louise criteria for CMR diagnosis of myocarditis, that was Matthias, who had this dream and vision that he put all together. More recently, he's been working on oxygen-sensitive CMR for detection of ischemia, which I think we'll hear about today. He has over 250 peer-reviewed publications, a founding president of the Canadian Society of CMR, a past president of the SCMR. And I still remember vividly, I was the president of the SCMR at the time, that Matthias was the chair of the SCMR Publications Committee 16 years ago when he made the bold proposal that JCMR move from a print edition to open access. And that really allowed the JCMR to, instead of being on 2,000 member desktops and perhaps 100 libraries around the world, to be accessed from the web, where now we have over 1 million accesses every year. He also runs a very popular monthly web-based CMR journal club with the first Wednesday of the month. I encourage all of the people interested in non-invasive imaging to attend that. He also is a co-founder of CVI42, another dream of his to make CMR analysis easy. And so he, again, is a founder of Circle Cardiovascular Imaging. And with that, I turn the podium over to my good friend and colleague, Dr. Friedrich. Matthias?
Thank you so much for your flattering introduction. And it's a special honor for me to be having been invited to give the Sven Paulin lecture. And I really, really appreciate it. And also it's a good opportunity to do something with you, Warren, whom I always respected as one of the leaders in the field with always a calm hand on the steering wheel. Today, I want to talk about, you mentioned the term dream, Warren. I want to talk about another dream, which is the possibility of doing an MR scan that provides enough information, at least for suspected myocardial ischemia, in 15 minutes or less, and without using a needle. So first, I want to disclose I'm involved, as Warren already mentioned, in software development because I believe that we, as a university, we can only do so much. Eventually, what we cannot do is bring the tools to the people who actually have to perform that. That's where we need industry. And instead of putting that all into the big pots of the big companies, I decided several times now to take things myself, because then you have much more control and you know about the quality, and it's not just about making money, but it's about the eventually impact on outcomes. So, but having said that, I'm advising companies. So Area 19 is important because Area 19 distributes a tool for oxygenation-sensitive MR. So be aware that I'm involved in that. Circle, I'm less actively involved in anymore, and then I advise a Canadian company on healthcare, and I have research agreements with some of the big vendors. So there are a few important trends in cardiovascular medicine. I think the most important is that we move to a value-based care where it's not about just paying for a service just like that, but paying for what this service or whatever I do does for eventually patient outcomes. This has to come in a personalized manner, so not just trying to use cookie cutter solutions derived from big clinical trials on anybody, but respect age, sex, ethnicity, special circumstances, lifestyle, genetic backgrounds, and so forth. And then we also, I think, have to, in terms of provide value, get to a diagnosis that is not just based on one finding or one tool, and imaging often has to carry that burden, but also is integrating data. And this data integration, that used to be the field of experienced clinicians who were able to basically get their head around but information now is so abundant that it gets more and more difficult even for seasoned clinicians to do so. So that's, I think, where artificial intelligence comes in. So I'll also allude to that a little bit later on. So in a nutshell, one of the most important aspects is what is the information we can get per dollar spent, and what's the value of this information for patient outcomes. And in that context, value-based care, personalized, and having to integrate a lot of data a technique has to provide a lot of information in the shortest period of time, and this information has to be typically quantifiable. And the best technology I can think of, and of course I am biased because I'm in that field, but still I'm too convinced that there is another even remote contender, because MRI is so versatile. You can do morphology imaging, you can do give contrast, look at perfusion, you can do tissue characterization, angiography, you can quantify flow, and all that you can do better than with any other technique, except for angiography, where CT is better because of a higher spatial resolution. Although this may be a limitation that it will not last forever. So it provides a lot of information. It provides the most quantitative data, even from a single scan. And it's therefore also best positioned for maximizing its output using artificial intelligence. So what are some of these strategies to increase the value? You have to reduce the effort, short protocols, no needle, no stress, no doctor standing next to the workstation, and no contrast agents, which is basically the no needle stuff, but no needle also means no vasodilators. And you have to increase the output per time. So maximize scan efficiency and image quality, not having to repeat certain images. Multi-purpose sequences, so sequences that can be used to extract tissue information and perfusion, for example, or ischemia. And analysis tools that do not require drawing contours, but do this automatically. And then integration of other data, as I mentioned before, heart rate, blood pressure. This is all available during the scan, and then integrate them into basically the decision making. And then also later on, you can also integrate mobile device data for the clinician later on there are smartwatches and cell phones everywhere that can gather data, which are often more valuable than just an office blood pressure, for example. So this is basically the framework or the backsplash of what I want to talk about today. Now let's go to the cardiac diseases. The most important cardiovascular problems are, of course, coronary artery disease and cerebrovascular disease, and then inflammatory heart disease. So what I think is underlying most of that is actually inflammation. And inflammation leads to all sorts of things, but eventually the consequences are coronary artery stenosis, endothelium independent microvascular function, or endothelial dependent microvascular dysfunction, then metabolism, a lack of appropriate oxygenation, and then the functional consequences. So these are the consequences of the disease, which could hit the coronary arteries first, or is most likely given the lifestyle that is unfortunately abundant. So we have as a cardiologist, or for that matter, internal medicine or general practitioner, you're often faced with the question, okay, does this patient with shortness of breath or chest pain have coronary artery disease that A, needs treatment, primary or secondary prevention, or B, a mechanical intervention? And that's why the first question is there a dysfunction of the coronary vascular system? Yes, no. And second, is there a lesion or something that can be mechanically approached? We know that, and I don't want to go down that route. I'm not a friend of elective PCIs in coronary artery stenosis. So you really wanted to know is beyond optimal medical therapy, is there something you need to do? And for that, you need certain information so that you could look directly for the stenosis. And there are some techniques, coronary angio, CT, and then the perfusion scans like SPECT or PET and CMR. And then for microvascular function, it gets more difficult. There we have only more let's say, less safe procedures like PET, where you inject a radioactive tracer. You can do this with CMR, and for the LAD territory also with echo. And there are certain markers. Then you can look at the metabolism. This MR spectroscopy has been around for a while, but has not entered clinical context yet. And then there's oxygenation characterization-sensitive MR, which I will talk about. And then, of course, you can look at the downstream impact. So these are the options we have. Now, in MR, when we talk about a 15-minute scan, the closest we can get there currently is probably first-pass perfusion. So here's an example of a lesion in the right coronary artery leading to a perfusion deficit. So you inject gadolinium into the vein and then you watch the inflow. And this technique has been shown to be clinically feasible and accurate. In fact, when you compare it with SPECT, you see that this is from data from Andrew Rice paper, which is currently has been submitted for publication, that when you, and these are data from the GATACAT-2 trial, basically a real-life comparison head-to-head CMR SPECT, and you see that it barely touches the accuracy of the CMR, so in this area under the curve analysis. So we have a high sensitivity, a high specificity, and compared to SPECT, also higher sensitivity, 74% versus 64% in this data set. And of course, all this accuracy doesn't help if it does not improve outcomes. So what I tell often students is, it doesn't matter whether images are beautiful or accurate, have a prognostic value and a cost efficient on that. That's all nice and important to some extent. But the real question is, does it improve outcomes? Does it help making lives eventually better? And this is what was addressed in the MR-informed trial, where the team could show that it's just as good as FFR when used for clinical decision-making. And the good news was that even came with less revascularization procedures. So perfusion scanning definitely does its job. It has a proven prognostic value. This is from the SPINS trial. So it helps reclassify patients properly. And in a recent study by Theo Pezel, who's now back in France, he could also show that even after 10-year follow-up, it's a very strong prognostic value, the result of the first-pass perfusion scan. Even when compared to CT, in symptomatic patients, MR turned out to be much better. And accordingly, the societal recommendations, these are the multi-societal recommendations, then have recently put MR also on center stage here. So could you do this in 15 minutes? Well, maybe, but the current protocol, it takes a little bit longer. So if you add, and this is maybe a mistake that the CMR guys like me have done, we always, of course, want to provide as much data as possible. So it was not just about the perfusion, which you could do in a few minutes, in 5 minutes, but it's also about getting accurate data on LV morphology, function, and things like LV mass, for example. And if you do that and you add scar imaging, then you're out of the 15-minute window. So this is 30 minutes. So we recently in Montreal, we timed a study, and it took us 27 minutes actually in total for this protocol. So this is not yet 15 minutes. And the first pass perfusion for myocardial ischemia has two disadvantages. One, or actually three. So one is it needs a contrast agent. That's the thing. And gadolinium is very safe. Don't get me wrong. I think the whole story about the fibrosis in patients with kidney failure, I think that was always overblown. In my career, I have never, with about 20,000 cardiac MRs, most of them contrast enhanced, I have never seen a case. I was never reported anything, but maybe because I never used more than 1.5 doses ever in any patient, and in a patient with kidney failure, definitely not. So all the cases that have been reported were with high. So don't get me wrong, gadolinium, I think, is a safe thing to apply, but of course it adds cost and it adds logistical issues, and in few patients it adds also inconvenience, or in some rare cases, allergic problems. So that's one disadvantage. The second disadvantage is it's not really ischemia imaging, it's just perfusion imaging. And perfusion imaging is nice for perfusion, but not necessarily for ischemia. We we always think we're talking about the same thing, but we're not, because you can have reduced perfusion and the tissue may not be ischemic because there are collaterals coming in from elsewhere, or the tissue is not really viable and doesn't need more oxygen. So, and also vice versa, if you have a good flow, but you have severe hypertrophy, you still can have ischemia. So perfusion is what it is. It's currently maybe the best we have. And then first pass perfusion also does not necessarily look at this here, which is microvascular function. So while there are papers out showing that maybe there is a subendocardial delay, there was back in 20 some years ago, but with adenosine, but this study was not actually that well done. And we also have to admit that the microvascular dysfunction does not necessarily come with a reproducible pattern in the perfusion scan, but it plays a huge role in understanding patients with symptoms of ischemia. Especially women are often affected by what is referred to as INOCA, ischemia with no obstructive coronary arteries. And this is a big topic these days. It even can come with troponin release, and it's called MINOCA, so myocardial infarction. So we have problems that are not necessarily easily visible with first pass perfusion imaging. And this is where oxygenation-sensitive MR may come in. The underlying principle is that, and this was actually detected by Linus Pauling in 1935. I have no idea why someone would have an urge to identify the magnetic properties of oxygenated versus deoxygenated hemoglobin, but he did that. And he found that deoxygenated hemoglobin has a so-called paramagnetic effect on the surrounding tissue. So it alters the magnetic properties of the molecules around them, or the space around them, because of the iron atom and the basically configuration in a deoxygenated state. If you use then sequences or MR protocols for that matter that are sensitive to this effect, then you can visualize more so regions with more deoxygenated hemoglobin, open parenthesis, that could be ischemia, close parenthesis, by a lower signal intensity. So we have sort of a contrast agent in vivo if we use a dynamic study, a study where it changes, where the oxygenation changes. So if we just look at it, signal intensity can be confounded by other factors. But if you leave everything stable and you change the amount of oxygenated hemoglobin, then then the deoxygenated hemoglobin will act as a contrast agent. It will get darker in this region. And we did that, for example, we had a blood pressure tourniquet around the leg, upper leg, and then we inflated it to 250 and then watched what happens in the calf, and you could actually watch the signal intensity go down with these sequences. This has been used since Ogawa's paper in 1990 for functional MR. And fast forward, we were one of the first in Berlin then to try this in the heart, where it's of course much more difficult because of the motion artifacts, distortion, etc. At that time, we used an echoplanar readout, and while we could show the principle, yes, during adenosine, there are in areas with severe stenosis, there is actually a drop of the signal. The scatter was huge, and so this was not yet something that was clinically really feasible, but we knew somehow it worked. And then fast forward, with the help of Baron Dharma Kumar at that time in Chicago, we used another sequence, which is a basic cine sequence that's just altered in a really non-significant way. It's the echo time has to be changed, and flip angle and bandwidth to some extent. But what we could show with that image, that technology where the image quality is much more robust, that we can identify areas during adenosine that do not show the typical increase of the signal intensity during adenosine, because more oxygenated blood is delivered. The oxygen demand stays the same, so there's just more oxygen, less deoxygenated. So signal intensity increases with adenosine in healthy people. If it doesn't, then here we could show that we could detect pretty much all the patients with a reduced fractional flow reserve. So the principle works. You can visualize if you change the oxygenation in the myocardium, in this case with adenosine, you can track these changes reproducibly. Now, fairly early on, I had, let's say, I thought in my really naive approach, I thought, okay, what if we just ask them to hold their breath as long as they can? So if they don't breathe, the oxygenation in the blood should go down, and we should be able to track that in the heart. And maybe in patients that's different from volunteers. And this is what I did before and after, and then we compared the signal intensity. So what we expected was that over time there would be a decrease of the myocardial oxygenation over the breath hold. But then what we saw was I was pretty puzzled by that. There was no change in patients. They had before and after, they had the same. And these are patients with hypertension, diabetes. So it was a mishmash of various patient groups. But then even more puzzling was what I saw in the healthy people. There was an increase. And this is, of course, what I initially didn't understand at all, and I was pretty frustrated. But then I just should have read my textbooks. And actually, the best paper ever published on that is from the 60s, and it provides a good explanation. So carbon dioxide accumulates, and you have to bear with me for that slide because it's very important. If you hold your breath, you do not breathe off the carbon dioxide. So carbon dioxide will accumulate, and you can do this for a while, but then the high carbon dioxide, also referred to as hypercapnia, will force you to breathe. So it's not the oxygen, it's the carbon dioxide which will force you to breathe. The urge to breathe and the panic, if you can't, comes from the CO2. And if you compare it with coronary blood flow, what happens is the body adjusts to the accumulating CO2 by trying to improve the situation for the most critical organs, which is the heart and the brain. And what happens in the heart of the brain is the following. If you hold your breath and you increase your carbon dioxide, then your blood flow increases. And if you hyperventilate, it's the opposite. You breathe off the carbon dioxide, so you go to hypocapnia, and then actually your coronary blood flow decreases. So the coronary blood flow decreases by up to 25% when you hyperventilate for 60 seconds. And then if you hyperventilate for 60 seconds and then hold your breath, you go from this point to that point of the curve. Even after 30 seconds, you already have a blood flow increase of about 100%. We did that in animals. It's actually in animals we could drive it up to 400% or 500% just with a breathing maneuver. So again, if you can modify your myocardial oxygenation by modifying your breathing pattern, hyperventilation decreases perfusion, and that's why people with panic attacks and emergency room, they often have chest pain because basically they breathe themselves into myocardial ischemia. Whereas the opposite happens with a breath hold. So it's somehow counterintuitive. So if you really want to improve your oxygenation in the myocardium, of course you should have enough oxygenation in your blood. That's one thing. But then if you hold your breath, actually you improve your oxygenation, not by panting. So this is the protocol that we have applied since. We have normal breathing, then we have a period of hyperventilation, 1 minute, and then we ask people to hold their breath. And this is often the question, yeah, but how long can heart failure patients or patients with coronary arteries hold their breath? Really, we often have problem with 10, 15 seconds. Yeah, that's true, but just try it. If you hyperventilate for 1 minute, and I would ask all of you listening here to try that at home. If you hyperventilate for 1 minute, then you take a deep breath and breathe out. You can relax for most of you probably easily a minute without even having to think about breathing. It's very interesting. And if you do that, if you train that a little bit, you can easily get to 2 minutes, 3 minutes. And people like those who had been the actors for the Avatar movie, I think they had to do this up to 7 minutes. But hyperventilation plays a huge role, because if you breathe off the carbon dioxide, it takes a long time until it accumulates to the point that you are forced to breathe again. So during this maneuver, you have a decrease of the carbon dioxide during the hyperventilation, and then an increase. And accordingly, in parallel, you have a decrease of myocardial blood flow and volume, myocardial oxygenation drops, and with that also the T2 star. So, and the T2 star is the underlying physical entity that is the basis for the signal intensity in the images. So we have done that in healthy people. These are actually athletes here. Even up to 2 minutes of breath hold, there's still a net increase on average of the oxygenation, and the opposite happens with hyperventilation. So this could be demonstrated. We then went to healthy people and compared it with adenosine. So here is what happens over time. In the LV cavity, you see there's not much change of the oxygenation-sensitive signal intensity. This is in the same images, so we're not not separate. So you really only after 2 minutes you have a significant decrease in the cavity, so in the blood oxygenation, whereas in the myocardium you have an increase that typically plateaus after 30 seconds. And when you compare to adenosine, with adenosine, you can also increase your oxygenation, your signal intensity. But as you can see, the delta that we can achieve with the breathing maneuver is pretty strong during hyperventilation, but then also during the post-hyperventilation breath hold. In animal models, we could then show where we implanted occluders and then generate a situation with a very well-defined FFR between 0.6 and 0.7. And we could show that compared to adenosine, the breathing maneuver, it's of course easy in ventilated swine to force them to these breathing maneuvers. We could show that the areas affected by the stenosis had a blunted response. And then to clinical application, these are data from Bern, from the Inselspital in Bern in Switzerland, compared to a healthy person, where the green indicates, now this is a map in a short axis view, green represents a normal response, whereas the blue and the darker, the more abnormal the response is, and even a decrease in some areas. And then there are also unfortunate patients where you have a global dysfunction, typically advanced diabetes or end-stage heart failure. And looking again at what happens over time, this is what happens in normal, the gray background here. The remote territory in patients with suspected coronary artery disease, or then with confirmed coronary artery disease, showed a similar profile, whereas in the stenosed territory, the breathing maneuver did not, so the breath hold did not lead to an increase, but actually stayed pretty flat. And then in the patients in this cohort with severe global microvascular dysfunction, there was even a decrease over time. And what the same group could also show is that it also has a role in heart failure. So actually, next to the global circumferential strain, the myocardial oxygenation abnormality was the most frequent observation in patients with HFpEF. HFpEF is a very interesting disease, which I think is caused by, let's say, a sensitive response of a myocardium that is very sensitive to catecholamines, just as Takotsubo, which is basically the maximum of what you can do as a catastrophic event. But I think that HFpEF is also a disease where it comes to repeated, basically like micro Takotsubos. So I think edema plays a role here, but we have not yet, we have some data. And here, a hint to that was also that the myocardial oxygenation response to the breathing maneuver was actually related to the septal wall thickness, and statistically not significant, but strongly trending also with T2 as a marker for myocardial edema. And about half of the patients with HFpEF have actually an increased T2, which would indicate edema, but that's another story. But in fact, why I'm saying that is edema leads to microvascular dysfunction. Microvascular dysfunction in that context is probably related to an increased diffusion space between capillaries and cells because of the edema, but then also edema compresses capillaries themselves. So we have two ways why the oxygen may not, or may only in a very delayed fashion, get to where it's needed. So all this microvascular world out there is not that well understood yet, and we will not understand it with perfusion imaging. We will not understand it with CT images. We have to have a marker that really goes there, and to me, the best candidate really at the moment is oxygenation-sensitive MR. So others have actually, this is data from Boston. Maaike van Boom, during her time there, used this in patients with hypertension, and could show a significant difference between healthy people and patients with hypertension. And these are data from China. They used just a 10-second breath hold after the hyperventilation, and could differentiate infarcted from salvaged and from remote myocardium. We have also applied, and this is the work from Heidelberg, the breathing maneuver with strain imaging, and in this paper by Marco Ox, so he could show that there was a significant difference in the response between ischemic versus non-ischemic segments. So the strain in ischemic segments dropped because the strain is a negative value. So basically it went up. So the overall excursion dropped as opposed to normal people. So there was a significantly different direction of the change. And so in this case, it could differentiate the strain imaging, and this was very fast. So the fast sync strain could, with the breathing maneuver, identify segments that are exposed to coronary artery stenosis, and that just took 60 seconds. In another study, also in Heidelberg, we applied this to patients with suspected acute coronary syndrome. So in more than 100 people with suspected acute coronary syndrome, we took the first troponin. If it was not conclusive, we sent them to the MR, which was just basically next door, did the breathing maneuver, and then continued their further diagnostic workup, and compared with a clinical consensus. Actually, the breathing maneuvers outperformed troponin and outperformed strain in their accuracy to identify acute coronary syndrome, with a sensitivity of 100%. So all patients with acute coronary syndromes were identified, but even with a specificity of 94.5%, positive predictive value of 77%, a negative predictive value of 100%, and accuracy of 95%. So this is not oxygenation-sensitive imaging. This is just to show that the breathing maneuver has a strong impact also on function when assessed using strain methods. Of course, as I said, even the best technology can get even better if you add other information. And this is what, again, the Bern team did. So they combined oxygenation-sensitive imaging with the map with strain imaging. And the nice thing is, using this technology here, you can extract the strain data from the same images. So you don't need to have another sequence. So it's all, you can take the oxygenation-sensitive images and then just perform a strain analysis. And doing that, what she could show that if you combine strain imaging with OS, you have the best of both worlds. So the oxygenation-sensitive had an area under the curve of 88. 0.88, the strain alone was 0.73, but if you combine them, you could get to 0.91, so very good diagnostic accuracy. Now, what do patients and referring physicians think of all that? And actually, we did that study, and was with over 300 participants. So breathing-enhanced cardiac MR was preferred by patients and by doctors, by referring doctors, of course, mainly because the lack of contrast agents, the lack of physical stress, and cost also played some role, but the most important arguments were safety and convenience. So it was deemed much more preferable than CT or stress echo or stress perfusion CMR for that matter. Some new developments. So this paper is in revision now. So if you add strain and oxygenation, that's fine. That's great. And area under the curve of 0.91 sounds very good. But you can even add more to that from the same scan. We have actually shown in a paper published in Scientific Reports a few years ago that the heart rate change during hyperventilation actually is also dependent on the cardiovascular health. So if you take a healthy young person and you let them hyperventilate for a minute, their heart rate will increase by 30, 35, 40 beats per minute. If you do that in a patient, and that doesn't have anything to do with beta blockers, this response is blunted. So there's a humorally blunted response to a thing like hyperventilation. And this has actually a significant accuracy, diagnostic accuracy, and a paper that we had presented at the CMR earlier this year actually could show that it even can discriminate patients who have a positive stress test but no coronary artery stenosis versus patients who have a positive stress test but with coronary artery stenosis. So so if you add the heart rate response to that, then you have 3 markers all acquired from the same 3-minute data acquisition in the scanner. And then if you do that, the negative predictive value in this was actually 97.4%, with a sensitivity of 94% to detect coronary artery stenosis. So how does this now look like? And this is kind of which I hope will then make it also, let's say, easy for those who are not well-trained cardiac MR people, but just clinicians. So this is how the heart looks like, the cross-sectional view, when you overlay a color-coded map of oxygenation. And this is in a patient with an occluded LAD. So as you saw during the cine, ischemia is not something static. A reduction of the oxygenation in a patient even with an occluded LAD is not there all the time. The oxygen actually will be reduced when it's most needed, and that's at end systole and very early diastole. So to me, this was a huge thing to see this first in real time, how this happens in the heart. So here's another one. This is an RCA stenosis. And the colors here mean that this is basically fully oxygenated, and the darker, the less it is. What we did here, however, to make it reproducible, we normalized the signal intensity here to the blood, which is fully oxygenated here, and of the left ventricle, and to the blood in the right ventricle, which is basically deoxygenated as much as this patient deoxygenates his or her blood. So this is basically a normalized oxygenation curve. And as you can see here during systole, you have that. Now, this is a very interesting case here. So this is LAD and circumflex. And here you might say, hey, there's a normal area within the abnormal. So what's that supposed to be? Is that false? Is that a problem there, or what happens? So and then if you look at the perfusion, it's actually confirmed that the perfusion deficit is most pronounced in this region. So you may think this is a false negative scan here. But then the solution is very simple. There's a subendocardial scar that was then detected in this patient in the late gadolinium enhancement. So when you go back, actually the perfusion was wrong, because the perfusion said the defect is the problem, the ischemia is there, but there's an infarct. There is no ischemia because there is no really oxygen, not a really strong oxygen demand. So, but what the perfusion missed is that around this scar is an area of reduced oxygenation. at least during systole. So this shows that this technique could also provide incremental information beyond what we currently can do, which makes sense because, as I said before, perfusion imaging is not ischemia imaging. Stress echo is not ischemia imaging. You image the consequences or the underlying cause. So you image a hypoperfusion or you image ischemia-induced dysfunction. But ischemia itself means the lack of oxygen, inadequate oxygen supply. And this is what you cannot do with the other techniques. Now comes the part of my talk where I have to talk about what we all have to talk about now, artificial intelligence. And of course, we're using that now extensively. And if you, because one way of analyzing that, or the best way would be if there would be hardly any interaction of a user, because a user can always try to can always come with a bias or can make mistakes, and not that machine learning cannot make mistakes, but it can do dumb things much better, especially when there are lots of data. And this is what we did here, and was presented in the papers and presentation, where we use machine learning for the fully automated analysis of the images. So dump all images across this 3-minute protocol. So you start the scan, run it for 3 minutes. For 1 minute, they breathe normally. For 1 minute, they hyperventilate. And for 1 minute, they try to hold their breath. And at least if they have at least 25 seconds, then we have good enough data. And then you throw these images into a software tool, and then let it just come out with a result, yes, no, for each coronary territory. And this is what we found, that there was a very high diagnostic accuracy to detect significant coronary artery stenosis. So overall, the model had 90% accuracy to identify significant and non-significant stenosis. So last, I want to show some data I actually presented also at the CMR of our international BMOR trial, BMOR for breathing-induced myocardial oxygenation reserve. And these are data from the interim analysis in 110 individuals done in several countries across the globe. And what we did here is we asked, can the BMOR study identify significant coronary artery stenosis identified by either QCA or FFR? All analyses were blinded, so there were different core labs who performed the analysis without knowing anything about the others. So these are some examples of that. So in a healthy volunteer, so this is a different color coding than before, where red means very high signal intensity increase during the breath hold. And then you see in single vessel disease or in multi-vessel disease, you see the blue indicating basically a drop in oxygenation. So because these centers, they were not necessarily used to the breathing maneuvers, because the breathing maneuver has a few very important aspects. One is they have to really hyperventilate, not just pant flatly, because you have to get rid of the CO2. And then they have to, the breath hold has to be at end expiration. It's very important, otherwise the test doesn't work, because if you do it in inspiration, there's so much surface in the lungs that it takes ages for the carbon dioxide to accumulate, because there's still a lot of surface to diffuse carbon dioxide from the blood into the lungs. So that's why you have to let them exhale and then start it. So given all the circumstances, we had a couple of issues, and we had to actually exclude 19% because there were just no breath hold images available. So that was during the early phase. The image quality was not that much of a problem. So 6% had to be excluded in patient and 3% in healthy. That's roughly what you also can see in other imaging modalities. So we had 48 patients and 60 healthy people, and the results showed that that normalized to left and right ventricular blood pool, we had a difference between healthy and patients, which was statistically significant, and again normalized to these markers. And we could identify significant stenosis in these patients with an area under the curve of 0.82. And the sensitivity and specificity, as you can see, are 85% and 79 or 78.6% when using a cutoff of 5.9%. Now, if we add basically artificial intelligence, we can actually improve that. Artificial intelligence could actually identify significant stenosis based on the texture in the images, on the change of the dynamics with an area under the curve of 0.899 and the sensitivity of 91.3% and specificity of 80%, 80.8%. So this is a correct identification of the territories exposed to significant stenosis. So not just detecting that the patient has coronary artery disease, but this is actually the correct territory. So there's more to come. Now we're currently also including actually information in the time domain. So we're not comparing just baseline breath hold or baseline hyperventilation breath hold, but we also go across the cardiac cycle, and you get something that we call OCG, oxygenation cardiogram. Also, of course, in analogy to the electrocardiogram, because you also have a curve with a certain specific shape. Actually, for each coronary territory, it looks slightly different, but still very similar. And then this shape changes in coronary artery disease. It changes in microvascular disease. And so there's a whole world out there, for artificial intelligence to use that. And as much as you can use now ECGs with artificial intelligence to identify things like diabetes from the ECG, with a sufficiently good accuracy, we expect that there is a lot of information in this as well. And all by this scan, where the actual data that we need for this analysis only take 3 minutes of a single push button technology. So let me conclude here. A needle-free cardiac MR protocol for morphology function and vascular function can be consistently performed within 15 minutes, because if you take the localizers and you do some cines, then oxygenation-sensitive cines in various views, at least one of them with a breathing maneuver, then you can not only look at the change, because these cine, they are regular cine images, you can use them for LV for morphology and function, but then also then with a breathing maneuver, and maybe in the future even without, but that's maybe currently more on the horizon. You can use the same images for all that, and we're also currently exploring the option of using this information of the tissue also for tissue characterization. But that's again in its infancy. Then AI-enhanced BMOR, so breathing-induced myocardial oxygenation reserve, is clinically feasible. And we have now experience in more than 1,000 people, including end-stage heart failure, including acute infarcts, acute coronary syndrome, coronary artery disease. And we have a paper now in revision where we could show that it actually correlates with vascular dysfunction in the brain, and in patients with heart failure, this is correlated with cognitive dysfunction. So a lot of interesting stuff happening also in the brain. But of course, and I know that almost every paper ends with that, we need more data, but in this case, it's pretty targeted. So we need to further validate, and others have to help us assess the clinical utility in various patient groups, and most important, the impact on outcomes. So does this technology really improve management and outcome in people? And we're very fortunate that we have not only, that I do not only have a wonderful team in Montreal and in Heidelberg, but that we now have 19 centers worldwide that are part of a consortium, including the Cedars-Sinai Medical Center, the NIH, we have the Imperial College in London. So lots of centers, including India, South Africa. Each of them has a certain topic. We'll compare it to PET or to acetylcholine injections and so forth. So we hope that over the next 2 years, we will have a lot of good evidence to find out about what this technology really can do. So I think we have, at least for me, for the first time, we have it in sight that there may be a non-contrast scan of less than 15 minutes in patients with suspected myocardial ischemia. And with that, I want to thank you for your attention.
Thank you very much, Dr. Friedrich. That was really fantastic. We have a couple of questions that have come in through the chat. One from Robert Gersten, who asked, regarding AI, please comment on cross-platform validation, given the black box nature of AI.
Yeah, of course, that's always a good question. So AI is definitely to some extent a black box, although AI also helps us to identify what is the best marker, and then it's not a black box anymore, because then you can test prospectively. So the validation will, of course, have to happen. So as I said, where we have teams. So, for example, Oreimi Quesada at the Christ Hospital, they're using intracoronary acetylcholine injections and compare it with coronary blood flow. It is very difficult to really validate the oxygenation itself, because you would have to go into coronary veins, and this is being done in animals, but in patients it's more complex. But definitely this validation is needed and will happen. And the AI, of course, has to be independently applied, so not just in the center that trained the AI in a certain population or whatever. And the AI is being trained in our center in 2,000 people of various ethnic backgrounds and social status, and is compared with lots of other data and also with outcome. So we're following these people. The follow-up currently is at 2 years, but we will wait for a 5 to 10 year follow-up. So that's, of course, an important point that has to be basically worked out. Yeah.
Thank you. We have a question from Connie Sao. Great talk. She was interested in your institution's policy on gadolinium administration in patients with advanced CKD and end-stage renal disease.
Yeah, so we are actually pretty liberal with that. We always say, but that's actually true for everybody, if you really need that scan for clinical decision-making, and ideally every scan should be like that, and not just LAPOLA. So if you need that scan for clinical decision-making and there is no other method that likely will provide sufficiently usable data, then we'll give that. And we can, although the data for that are not very strong, but we sync it then with the dialysis if they are on dialysis. But otherwise, I always give, and I have always done that in patients, even with severe renal failure, if it's an important indication, a single dose, so never more than that, at least not within a week. We'll do that. And we all have had good experience, and had similarly good experience in Calgary or in Berlin. So I think that is a reasonable approach.
Great, thank you. I'll turn it over to Warren, who has a question.
Matthias, that was great. Wonderful lecture, very exciting. I think Sven would be very happy. I had two questions. One is that, how does the BOLD technique perform for distinguishing between patients with multivessel disease and microvascular disease, such as we commonly see with diabetes and hypertension? And the second question is, when you do MR perfusion with gadolinium, something that you get sort of for free is late gadolinium enhancement, which in fact you showed that one example where LGE was helpful in interpreting the BOLD technique. So what are your thoughts?
Yeah, excellent question. So the first one regarding multivessel disease versus microvascular dysfunction. I do not feel comfortable giving you an answer that sounds definitive, but from, let's say, our anecdotal experience is, and then some of the images showed that multivessel disease, at least in those patients where we have seen that, always is way more pronounced in the subendocardial layer, and it has areas that are not as bad in the transition between vessels, and in the basal segments, it's also usually not that bad. Whereas in severe microvascular disease, it was more global, it was very patchy, but definitely not confined to a certain layer or region. In fact, we have one paper published in Circulation where we looked at that in patients with INOCA, and found that they had overall the oxygenation was not actually different in these people. They were not very sick, but they had what you would call atypical angina or angina with no coronary artery stenosis. But then when we looked at the heterogeneity, their oxygenation response was very, very patchy. And this patchiness, basically, if I'm allowed to use that word, actually predicted those with these symptoms. So I think it's too early to say, but I'm very optimistic to answer that question. The other one around late gadolinium enhancement, yes, that's a very important point. And so far, I think a non-contrast protocol, at least for this time, would have to include a T1 map, and T1 maps, native T1 maps, if they're very good, actually have some potential to detect if you're careful with your scanner settings, because you can get out of phase and then you won't see it very well. But in a well done T1 map, you can identify that. But again, here, I think there is more in the T1 maps that meets the eye of just a reader. There are also things about the texture of the myocardium. There are a couple of papers recently that have been published that show that there is a significant potential of non-contrast techniques, specifically the T1 maps, to identify scars. If not, then you would have to add to the scan that we can now perform in probably 8 minutes. You would have to add another, let's say, 8 minutes, 10 minutes for the late GAD, because you cannot do the oxygenation sensitive after a contrast injection. You have to, after contrast injection, the T2 star will drop everywhere, and so then basically the game is over for oxygenation sensitive MR. But I agree that is still currently a limitation. So if you are interested in viability at this point in time, you definitely would still need to give contrast. But for the future, I hope, and we have also some data. We have also one abstract that we showed that where we could not only detect in a blinded analysis the late gadolinium enhancement scar, but also quantify it with a good agreement. So I think we may go there, but mapping has his own, let's say, idiosyncrasy. So mapping is also not necessarily as good as some people may want to believe it. So that is definitely still an area of construction, for sure.
All right, well, it looks like we're at the hour. So thank you very much, Dr. Friedrich, for a really outstanding Sven Pollen lecture. It was a pleasure to host you. And for everyone else, we'll see you next week.
Thanks for inviting me, and all the best to everybody, and have a good weekend.
Bye-bye.